record jalan. Oh, dia lu.
Welcome everyone. Thank you for joining us with this webinar about case and updates about the shoulder pain or frozen shoulder. Now we announce first about the course that held by the PainManagement.Network. There are two kinds of course. The first one is the pain management course. It will held on August until November. And then the intervention pain management course. There are two. The first one is the basic one or the musculoskeletal. Will be held on the August until October because this is the 3-month learning. And then the intermediate or the nerve it will be held on September until the November. This evening, also Dr. Novy as the presenter of the case and update of the frozen shoulder. Good evening, Doctor.
Halo, good evening, Dr. Vitaka.
Hello, Doctor. We start now.
Well, okay, sure. Good evening, everybody. Maybe good morning or good day or good afternoon, because this presentation can be seen all over the world. Okay, our case and updates today is about case from a 51 years old lady who is our housewife, lives in Cipanas. Cipanas is about 90 kilometers west from Bandung. She was Muslim, Indonesian, married, and her vital sign was within normal limit except for her blood pressure a bit high, and the functional status is independent. Okay, this is just usual. This lady came with chief complaint of pain at right shoulder radiating to the right neck since 5 months ago. So when this is heard by you, then you will be thinking of 1 or 2 or 3 differential diagnoses. Okay, I'd like to actually have conversation, dialogue with maybe 1 or 2 of you, so that the case and updates presentation will be more lively. Okay, so if any of you want to become volunteer to have discussion with me, please feel free to just unmute your recorder, unmute your mic, or just let Dr. Vitaka know or one of our administrations here. We will let you in. Okay, and then back to the chief complaint. The chief complaint has already treated by several doctors and physical therapists, but then the patient has stopped it since 3 months ago because there was no improvement at all. Okay, so I see here there's Dr. Wahyuni, Dr. Teni, Dr. Neta, Prof. Fausia, and if there's any other else in the Google Meet who is willing to become volunteer to discuss with me, please. Okay, so if we have a patient like this, then what are you going to ask to the patient more? Is this statement enough, or you want to add more question? Okay, you can type it or you can raise your voice. Okay, body, so then I will be my counterpart. Okay, so if we are talking about pain, then I will be eager to know how severe the pain is, right? The pain was in the numeric rating scale 4 until 6, sometimes 10 in the 10 scales of numeric rating scale, so it's quite high. And the pain was getting worse from day to day. So try to imagine it. And the pain was reduced by taking a rest. Okay, have you already imagined it? Before, Dr. Vitaka has already told you that this case will be about frozen shoulder. So it's a clue, but it will be distracting our way of thinking that this is a frozen shoulder case. It's all right, but it's not as simple as that. Okay, because the patient said that there's radiating pain from the right shoulder to the neck, so we must be thinking of something else than nociceptive pain. So maybe there is a radiculating pain that comes from the neck. Okay, so I asked the patient about, is there numbness, is there tingling sensations at the neck, upper back, shoulder, and right arm and hand, and the answer was none of them. Okay, and because we are talking about shoulder, I thought at the time that maybe because she was 51 years old, maybe she suffered from degenerative diseases at the shoulder, which is arthritis. So I asked her about morning stiffness. There was morning stiffness. Okay. Do you want to add some more question? No? If I have a statement that I have morning stiffness, there should be another question related to the morning stiffness, which is how long the morning stiffness lasts. 5 minutes, 30 minutes, 1 hour or more? Why? Because if then the morning stiffness lasts for more than 1 hour, we must thinking about rheumatoid arthritis. If less, maybe the patient suffered from osteoarthritis. Okay, so I will jump to the next slide if there is no other question. Okay, so if you want to add some more question, please be prompt. Okay. Okay, then from this chief complaint, there's another information that the patient have suffering from bathing, grooming, because when she left her right arm, it was very painful, and sometimes she couldn't sleep because of pain at the right shoulder. Okay, so then from these chief complaints, I add some more information that there is no allergy of medication. She took mecobalamin but was stopped due to dizziness, nausea, and vomiting. And from the history of past illness, there's hypertension, no trauma. Why? Why I want to ask about trauma? Because there is head, neck, shoulder pain. If there's trauma, maybe the differential diagnosis and the anamnesis and the physical exam will be different. Okay, there's no trauma. So then, from the information got, the differential diagnosis were the first, frozen shoulder. Okay, but because there's something else, there's radiating pain.
So the scope is possible. How about the wrong restriction? Maybe later on the physical.
Yeah, in ADL, it's already stated that the ADL was disturbed because when the patient moved her arm upward, it was very painful. So there is range of motion limitation. Okay. If my first differential diagnosis is frozen shoulder, it's about shoulder, right? In shoulder, there are so many structures, which some of them are rotator cuff, right? So there might be rotator cuff tendonitis or tendonitis, and then because there's radiating pain, it might be radiculopathy, cervical radiculopathy. And if we are talking about frozen shoulder, we must differentiate it from osteoarthritis, right? But then because the pain were at the shoulder, upper back, neck, maybe it's only myofascial trigger point syndrome. Okay. Any else? Any differential diagnosis from you? Okay, so then these were my differential diagnosis at that time. So I must work up all these differential diagnosis into the physical examination. Okay, so what I did was this one. Okay, I examined the patient from the head and neck, upper back, shoulder. Okay, at the head and neck, this is the positive sign only. I previously, before I do the head and neck and all the examination, I look at the patient. So the rule is always look, feel, move, right? From the appearance of the patient, it seems symmetrically from the left and the right. No tendency to be leaning to the left or the right side. Okay, at the head and neck, the head and neck is symmetric, and when I ask the patient to do active range of motion, flex forward and then extend neck, there's no pain, but there's pain at lateral bend like this and lateral rotation, and the pain was felt more at the right than on the left of the paravertebral cervical area and the right upper back. And from palpation, there was tenderness at the right upper back. Okay, and there's tightness also there at the right upper back and also at the paravertebral cervical area. And when I did Spurling test, the Spurling test was negative and the distraction test was negative. Okay, so from this examination at the head and neck, I've already excluded one thing, which was the radiculopathy cervical. Okay, but the MTPS was still there. Okay, and from the upper extremity examination, from the appearance of the patient, there's no asymmetry from the left and the right shoulder. There's no scoliosis. Okay, and in the active range of motion at the shoulder at the right side, there's limited range of motion in abduction and flexion, and pain felt at 90 degrees of active abduction and flexion, and the anvil was firm. The limitation of range of motion happened also at external and internal rotation, not only actively but also passively. Okay, and when I moved her shoulder, I felt no crepitation at the right shoulder. So excluded also maybe the osteoarthritis. Okay, but because of the range of motion, especially for abduction and flexion, only 90 degrees, then maybe there's still osteoarthritis. Okay, and then because the differential diagnosis includes also the rotator cuff tendinitis or tendonitis, so I check all the rotator cuff muscle. The abdominal press test was positive at the right side, and then Hawkins-Kennedy test slightly positive, not too painful when she did the Hawkins-Kennedy test. Okay, so then what was the diagnosis? Okay, from this examination, from the previous differential diagnosis got from the anamnesis, from the history taking, I'll show you again. First, the differential diagnosis is frozen shoulder, rotator cuff tendinitis, radiculopathy, MTPS, and osteoarthritis, right? The spelling test was negative. The dissection test also negative, so there should be no radiculopathy, right? So, from all these 4 differential diagnoses, the most probable diagnosis for me is the frozen shoulder, but still there is probability to be tendinitis of the supraspinatus, because the Hawkins-Kennedy test was positive, although it's vague, and also subscapularis tendinitis because the abdominal press test was positive. MTPS also can still be the diagnosis because there's tightness, there is head and neck pain when the patient did the range of motion, especially to the lateral and rotation to the left and right. Okay, but for the osteoarthritis, still possible also. Yeah, because the range of motion only 90 degrees. Okay, so the most probable diagnosis still for me is frozen shoulder. Okay, for me the diagnosis is frozen shoulder. Then all the 4 except the radiculopathy. Okay, the diagnosis was frozen shoulder, right frozen shoulder. Okay, if there's argument, please.
Can you say we also agree about the shoulder? What about the referred pain to the neck?
Yeah.
Because referred pain to the neck also the differential diagnosis with the MKes.
Okay, great. I agree with you. Not because I've already examined the patient and I've done several things, but that was my opinion also at that time. Okay, so then related to the diagnosis, although there are still some differential diagnosis, I'm 99% sure that it was frozen shoulder. Okay, so I proceed to the problems. The problems in this patient were, first was pain, and then the ADL. The ADL were disturbed. ADL is activity of daily living, disturbed in grooming, bathing, and sleeping also. Okay, lack of sleep because of pain. So then, from the diagnosis, I have problems. I have goals. Okay, my goals were, first is to reduce the pain. The second was to improve the activity of daily living by improving shoulder range of motion. Because if the range of motion of shoulder only 90 degree? How can I comb my hair? How can I take a bath properly? And when I slept on my right shoulder, it will be painful. So then the next was to improve sleeping quality. And by doing so, I will be able to improve the quality of life of this patient. Okay? Do you agree or disagree? Please feel free to say so. I will proceed. Then, from these problems and goals, I do my management. My management to reduce the pain is by doing blocks. Okay, thank you. And so then the management for the pain, I do the suprascapular nerve block, the right suprascapular nerve block, using lidocaine 1%, 5 cc, and triamcinolone 10 milligram, because I want to have a quite long-term pain-free for this patient, so that then the next goal is to improve range of motion, right? So then I will be able to ask the patient to do exercise to mobilize her right shoulder. After doing the suprascapular nerve block, the numerating rating scale was reduced and the range of motion increased to 120 degree, quite a lot, on abduction and flexion. And then after doing the nerve block to reduce the pain, I do glenohumeral intracapsular injection using lidocaine 1%, 10 cc, and triamcinolone 30 milligram. Why? Because I want to reduce the inflammation happen in the glenohumeral capsule caused by the frozen shoulder. Because thinking about that, the frozen shoulder has happened on already for 5 months. It's in the subacute phase where inflammation is still there. So I do the glenohumeral joint injection. Afterwards, the range of motion still stopped at 120 degrees. So then my goal, some of my goal has already achieved directly at that time. The pain reduced, the range of motion increased, but still I need more improvement in range of motion. Okay, so because I've just done intervention procedure that might cause pain to the right shoulder, I gave the patient paracetamol 3 times 750 milligrams, 3 times only. And then right at that time, I give exercise to the patient to mobilize the right shoulder, which was actually it is a rehab stuff, to do step ladder exercise, to do power exercise. I will show later on at the next slides, okay? And afterwards, I ask the patient to do pacing. Pacing means that patients should be able to stop whenever she felt pain in all activities or positions, because there should be no pain more than the scale of 3, means that the mobilization or the activity of daily living should not add some more inflammation to the right frozen shoulder that just been treated by me. Okay, any comment? Agree? Always agree. Please feel disagree. And this is the here is suprascapular groove. Okay, this is a video actually. This is suprascapular. Oh. This is suprascapular. This is no. Oh, let me see. Let's try again. Okay, this is okay. I try to draw something. Ini? Mana? Okay. I try to draw something here. This is please. So then, it's just review for you if you have already done the musculoskeletal ultrasound learning and nerve. To do the suprascapular nerve block is by placing the probe at the just cranial to the spina scapulae, one lateral third at the supraspinatus fossa. Put the linear probe there transversely, and then we'll see this structure. This is issues. So this is supraspinatus muscle, and this is suprascapular groove. Okay, where above the suprascapular groove is transverse ligament, and inside will be the artery, vein, and nerve of suprascapular. Okay, so then I will back to the slides. We'll play the video. Okay, the needle is inserted from medial to lateral side into the groove, and see after the medication is put into the groove, the transverse ligament will bulge up. Okay, then using color actually to determine where the artery and vein are, we are avoiding those structures because we are only infiltrating the area to infiltrate the nerve only. If you do aspiration and there is blood, we insert the needle so that the vascular will be avoided. Okay, and then there's no other picture. Suprascapular only. This should be picture also about the procedure into the glenohumeral joint previously. Okay, for you who joined the learning program, we will distribute the PowerPoint if you need it, but how to do the glenohumeral joint injection to depot the lidocaine and the triamcinolone there, because the inflammation that causes the frozen shoulder happen. Okay, so then after doing the interventional pain management, you can see here, this is the video also. We must re-examine the patient right after the IPM is done to see if the goals that is our target already achieved or not yet. Okay, and is the problem is still there, or which problem which are still there. Okay, you see the range of motion, abduction now is more or less 120 degree. Actually, we must measure from below and going up, abduction, here, full range of motion. Okay, Hawkins-Kennedy test, like this. Okay, but no voice here. Okay. Is this the same? The same. Okay, so right after the IPM, I re-examine the patient. Lateral bend, rotation, the pain then reduce. The active range of motion of the right shoulder for abduction and flexion increased to 120 degree with pain 0 until 2. Okay, the end feels still firm, and there are still internal and external rotation, but already reduced. Okay, the abdominal press test negative now. The Hawkins-Kennedy test still there, but already reduced also. So then, is diagnosis now frozen shoulder or else? Is there any comment? Supraspinatus tendinitis, maybe yes, maybe no. Okay, because the range of motion is only 120 degree active and passively. Okay, maybe yes, maybe no, because the Hawkins-Kennedy test was still positive, but less painful than previously. Okay, any else? Okay, I continue. For me, the differential diagnosis for frozen shoulder, of course, my first differential diagnosis was frozen shoulder, and I've done intervention to treat the frozen shoulder also, and because there were improvements for me, the first differential diagnosis was still frozen shoulder. Rotator cuff tendinitis, which was supraspinatus tendinitis, might be still the second differential diagnosis, because the Hawkins-Kennedy test is still positive. Okay, MTPS might be the third.
Active mean that tendon or muscle, not
Yeah. Exclude. Okay, the osteoarthritis is still possible because the range of motion is not full. Okay, we must re-evaluate the patient in some more time. Okay, although my diagnosis was still frozen shoulder. Okay, but the differential diagnosis was still the four of them. Okay, so then what should be done? We must see the patient for evaluation. Usually I do 1 week re-evaluation. So then I will know what was the exact diagnosis. Okay, So by doing so, I gave the patient this exercise. This is so-called step ladder exercise. For non-rehab doctor, you can adopt this one. This is shift 100 and maybe 140 degree, right? This is for flexion, and for abduction also like this, like climbing ladder. Okay, here for abduction, you see, patient touch the wall all the time to prevent sudden movement that causes pain. Okay, and then this one already. Okay, then because the limitation also happen in internal and external rotation, I give towel exercise like this. The suffered shoulder was the right side, but we treated both sides because of the internal and external rotation movement. Okay, just like we after bath towel ourselves. Okay, this one is wrong. Okay, the first one is right. Okay, so if you don't know how to do it, just simply refer it to rehab doctor nearby. Okay.
The pain release, but the wrong is not full, so we have to give the wrong exercise.
Yeah, exactly. That's why I gave the patient a step ladder exercise and the towel exercise. Evaluation in 1 week later, agree, and it's done. Then the next week, the evaluation was I evaluate the problems previously in these patients: pain, activity of daily living, and sleeping disturbance. Okay, and at the time, after 1 week time, the achievements were the pain reduced to 0, and the score will increase to 2 when the patient did exercise, step ladder and towel exercise is okay. Less than 3 is okay. And then she could then comb her hair, take a bath without not so much pain. She could sleep well. That's good news. Okay, and because then she could sleep well, the idea improved also. She was happy, means that the quality of life is improved. So then from all the problems, now I must re-examine objectively. Okay, from the head and neck, lateral bend and rotation, no pain now, and upper back tightness slightly only. From the upper extremity, the active range of motion and passive range of motion increased to 160 degree and feel still firm. The external rotation pain still there, but not so much. The Hawking-Kennedy test, negative now. Okay, the abdominal press test, negative also. So then the diagnosis was the rotator cuff tendinitis must be excluded, right? And the osteoarthritis, maybe yes, maybe no, right? Last week differential diagnosis were frozen shoulder, rotator cuff tendinitis excluded already. Myofascial trigger point syndrome excluded, should be, right? But still a bit. But it's because referred pain from the frozen shoulder pain. Okay, so then now the last differential diagnosis is only osteoarthritis, which is very common in a 51 years old lady. But because I've already treated the glenohumeral joint, so then if there is osteoarthritis, it should be already treated. Okay, so means I must treat it the frozen shoulder. Okay, agree?
Shoulder, differential diagnosis, MKes, FIPP, and
Yeah, no deltoid problem. Okay, because if we treat all the myofascial trigger point syndrome, we must treat all muscles, because once there is pain in one part of our body, the muscle spasm, the muscle guarding will happen to protect the painful area. So what we should do is to treat the source of the pain, then the myofascial trigger point will go. Okay, so then the diagnosis was frozen shoulder with improvements, and from the last week problems and achievements, now the problems become ADL only. So the goal now is to improve ADL by improving shoulder range of motion. So we can see from day to day, only in 1 week time, we achieve a lot of things by doing interventional pain management. Okay, by improving the ADL means we improving the quality of life of patient. Okay, any comments? Okay, Dr. Tenny said frozen shoulder, agree. Okay, so then the next management is to reassure the patient about the disease that she has and give education how to treat her right shoulder, about pacing again, about daily activity should not exceed numeric rating scale of 3, not to reoccur the pain. Okay, although the suprascapular nerve block has already been done. The exercise should be done every day, regularly. The paracetamol should be stopped, and actually has already stopped after 3 times taken by the patient. And as addition, I gave the patient neck muscle and upper back muscle stretching exercise. Okay.
So we also set education for the ADL and the
Okay, and then to be follow up in 1 week time. If the patient can do all the do and don'ts, such as Dr. Tenny said, then the follow-up should be done in 1 month, because the blocks maybe has come to an end, and pain, if the pain comes back, I must do another blocks. Okay, so that's the case. Oh, this is your case.
Don't forget, doctor, the PainManagement.Network has a course next on the August, September, and October. There are 2 courses. The first one is the pain management. It will occur in the August until November, and the second one is the intervention pain management, basic and also advanced, for August until also November.
Okay. After the ad. Thank you. So about the frozen shoulder. Okay. Frozen shoulder.
I want to ask about the range of motion. We have to do the normal range of motion or until
functional range of motion. But because the problem is the adhesive capsulitis, which happen, I will review it later on. It should be treated. If not, then the pathology will not resolve 100%. It will be a problem. Okay, so we must resolve the range of motion as much as possible, because the range of motion should be reach the maximum range of motion. It's different from, for example, if the patient has broken bones or burns, that might be the range of motion cannot be reached fully. because of the anatomical restriction. But in frozen shoulder should be as much fully as possible. Okay, because the pathology comes from the inflammation. Okay. So about the frozen shoulder, here is at the left is normal shoulder, the right is frozen shoulder. It's adhesive and very structured. Okay, the name frozen shoulder, the other name is adhesive capsulitis, means that it is inflamed and fibrotic in the capsuloligamentous tissue. Okay, Cotman said that it is a condition that is difficult to define, difficult to treat, and difficult to explain from the point of view of pathology. Why? Because actually the cause is still unclear till now. But the stiffness and the painful shoulder is very clear, seen in all the frozen shoulder patients, means that the painful condition with limited active and passive range of motion is the key to diagnose the frozen shoulder. If actively the patient cannot move fully the range of motion of the shoulder, but then passively we can move, it is not frozen shoulder. Okay, maybe it is in all range of motion. It can be also in two planes of range of motion only. Depends on the severeness of the problems. The differential diagnosis for frozen shoulder depends on the symptoms and signs found in the patient. In the last case, I assume that she probably had radiculopathy, but can be in other case cervical facet arthropathy referred the pain to the shoulder, tendinopathy of the rotator cuff, thick tears at the rotator cuff, or impingement or bursitis. Can be osteoarthritis also, as the previous case, depends on the sign and symptoms again. Okay. To review the anatomy, this is our shoulder. This is the clavicle seen from the front. This is the scapula. This is the humerus with the humeral head. And this is the bicipital longus tendon with the transverse humeral ligament covering it at the head of the humerus. This at the lateral is the greater tubercle, and this is the lesser tubercle, which is the attachment of subscapularis tendon, while the other rotator cuff attached to the greater tubercle of the humerus. Okay, here is so-called the labrum is at the here at the scapular side. This is so-called the ligaments on all the capsule that cover the glenohumeral joints, where the adhesive adhesive capsulitis will happen here. Okay, it is a cross section coronally. You can see here this is deltoid muscle, this is acromion and clavicle, this is AC joint, this is supraspinatus muscle, this is coracoid process, this is the labrum. This all is subscapularis muscle. Okay, actually the glenohumeral joint, the shoulder joint, consists of a closed circuit starting from the here sternum. Could you please give me the mannequin? So once we have frozen shoulder patient, we must examine actually all the shoulder girdle here, starting from the, this is clavicle. Can you see it? This is clavicle. This is sternum. This is acromion. Okay, acromion comes from the lateral edge of the spina scapulae. Okay, this is scapula. This is spina scapulae. This is the acromion. The acromion will join the clavicle through the acromioclavicular joint here. Above the spina of scapula is a fossa, supraspinatus fossa. Okay, the subscapularis muscles lies here at the anterior side of the scapula, and the joint related to one another, glenohumeral joint, through the AC joint, acromioclavicular joint, sternoclavicle joint, AC joint, glenohumeral joint, scapulocostal joint, and then costotransverse joint. It is a closed circuit, so once the glenohumeral joint becomes frozen, then if it has already become chronic, then might be it will be painful at the costoscapula junction, or even in the costotransverse junction, or even the AC joint, or even the sternoclavicle junction, because then it is all related to each other. Not only that, all muscles, like in the previous case, can be interfered also. So then the patient might have pain in the muscles, myofascial trigger point syndrome, or just myofascial pain at the upper back, at the neck area, even can cause headache. Okay, so we must examine all the related structure to the shoulder. Just previously I showed you. I examine first the neck and head before I examine the shoulder, and I also examine the upper back. Probably there will be low back pain problem also at the thoracic wall, pain also. Okay, because it is related, it is linked to each other. Okay. Then this is the cause of frozen shoulder. There's primary, there's secondary cause, there's intrinsic, there's extrinsic cause. It can be caused in diabetes patient, in cardiopulmonary disease patient, in rotator cuff tendinitis patient that becomes chronic and then become frozen. Okay, the etiology and pathology actually remains unclear. The evidence identifies elevated serum of cytokine levels, so that's why it is thought that the inflammation is the cause of the frozen shoulder. The cytokines and other growth factors facilitate tissue repair and remodeling as part of the inflammatory processes actually, but then the healing response can lead to excess accumulation and production of fibroblasts releasing type 1 and 2 and 3 collagen that will exaggerate inflammatory response that leads to arthrofibrosis that happens in the frozen shoulder cases. And studies report there focal vascularity and synovial angiogenesis, which is increase of papillary growth rather than synovitis. Synovitis means might be there is arthritis, so it is capsulitis. However, it is agreed that whether it is angiogenesis or synovitis, that pain accompanies the change. And from open and arthroscopic examination, it is demonstrated that significant capsulo-ligamentous complex fibrosis and contracture happen in frozen shoulder cases. And there's also contracture of rotator cuff interval. Okay. Any comment? No? This is rotator cuff interval. I will not talk about it. The characteristics of primary frozen shoulder is the age, usually 40 until 70 years old. It is insidious, means gradually, happen after minimal trauma, even no trauma at all. That's why I asked about trauma in the previous case. Significant night pain, because when we sleep, we cannot control our position, we cannot control our movement. When we move sudden hours like that, okay? Or if then the shoulder become pressed when we lay at the side of the shoulder pain, it will cause severe pain. And it causes significant limitation of active and should be in passive also shoulder range of motion in more than one plate. Okay. There is 50% or greater than 30 degrees loss of passive external rotation. Okay, because the movement of shoulder consists of abduction, flexion, internal and external rotation. Once it is frozen, means usually the external range of motion also disturbed. All end range is painful. Why? Because it is frozen. Once it is frozen, at the end of the range of motion, when we push the patient to do more, it will be very painful because then it is tried to be broken. Once our tissue is broken, then there's tissue damage, means pain. And significant pain and or weakness of internal rotators. That's why the abdominal press test is positive at this patient. Okay, this is about the severity of the frozen shoulder. We may use it, we may not use it. Depends on you, what you want to do. I don't use this one. And talking about the stages, there's some classification. I use the acute phase, subacute phase, and chronic phase. These stages divided the adhesive capsulitis of frozen shoulder into 4 stages. The first stage happens in the first 3 months, where there is pain in active and passive range of motion, limitation especially in forward flexion and abduction, also in internal and external rotation. And if we do examination under anesthesia, the range of motion usually normal. Why? Because the patient cannot resist the movement because of the pain, but then afterwards the pain will come back soon, right after the anesthesia is gone. Okay. In arthroscopy, it is found synovitis in the glenohumeral, especially the anterior superior capsule. So, if we do the suprascapular nerve block, which covers most of the posterior part, means that the pain is still there actually, because the anterior superior capsule is the pronounced pathology if we do arthroscopy. And there is hypervascular synovitis also in the first stage. So means this is a lot of inflammation. In the previous case, the duration of the 5 months. So it's already in the second stage, which happens in between the 3 and 9 months duration. The pain is already chronic with active and passive range of motion. The limitation is just the same in the first stage, and the exam under anesthesia is similar to the first stage. But in the arthroscopy, we can find diffuse pedunculated synovitis, means that the synovium become hypertrophic. Hypervascular synovitis, subsynovial scar, and fibroplasia, means that the fibrotic become fibrotic. But the pain has already reduced. Okay, at the third stage, at 9 until 15 months of duration of pain, the pain is already decreased a lot, except at the end of range of motion. The significant limitation of range of motion can be felt as rigid. At the first and the second stage, it will be felt firm. Firm is like when I extend my point finger like this is my maximum range of motion, but if I try to do more, it can be move more. At the end, I can still add more. It is firm. Okay, this is how I extend my point finger, like that only. But if I add more passively, it can move more, but it's already firm. Here at the end, I can still add more. It is firm. Okay, but if it is said rigid, rigid means if I flex my elbow like this, okay, and I press more, it is hard. Rigid, cannot add more. Okay, it is rigid. And the exam under anesthesia, identical, such as when patient awake. In arthroscopy, no hypervascularity, fibrotic synovium, diminished capsular volume. And the capsule shows dense scar formation, means that at this stage, the inflammation is almost disappeared. Okay, when we found patient of frozen shoulder in this stage, almost no pain, means that we don't need to give steroid injection into the glenohumeral joint. Okay, at stage 4 happens at 50 until 12 month duration. Pain is already minimal. There is progressive improvement in range of motion. So if I have patient of frozen shoulder, if she or he doesn't want to be treated, I simply said that, yeah, you can be cured, but in 2 years' time with pain. Although at the end of the time, there will be no pain and the range of motion will be gained again. But not always, because sometimes it becomes contracture and cannot do daily activity. So another classification, this is the freezing phase, frozen phase, and thawing phase. The freezing phase, from the 2nd until the 9th month, patient may experience the gradual onset of diffusing pain in the shoulder that often increasing at night. So this is the 1st and the 2nd, or maybe the 3rd stage of the frozen shoulder. And then frozen time happens in between the 4 months until the 12 months. Patient may experience the progressive loss of range of motion, although pain will subside. The thawing means already no frozen states anymore. The range of motion will gradually return for the patients. So similarly, this phase is important for us to do treatment. Either we want to do rehab treatment or medicamentos treatment, or are we going to give intervention to the patient? Okay. This one is just the same as before. It is said that we should rule in adhesive capsulitis as diagnosis if we found the patient's age is between 40 until 65 years old, but I found a 11 years old boy suffering adhesive capsulitis because of trauma, because he is a badminton player suffering for pain for, I forgot for how many months, but yeah, several weeks ago, frozen shoulder in 11 years old boy. So this is not always should be like this. Okay, the patient reports a gradual onset with progressive worsening of pain and stiffness because of the timeline of the progressiveness of the adhesive capsulitis, and pain and stiffness will limit the sleeping, grooming, dressing, and reaching, which are the activity of daily living of the patients. And glenohumeral passive range of motion is limited in multiple directions, the same as the active range of motion. Okay, the glenohumeral external and internal rotation decreases as arm is abducted from 45 to 90 degrees. Here, the internal external rotation is decreased and that range of motion in abducted arm. And passive motions into the patient's end range of motion reproduce the patient-reported shoulder pain. Okay, joint glides or accessory motions are restricted in all directions. This is theory. And we must rule out frozen shoulder if the passive range of motion is normal, because then it's not frozen. Okay. Radiographic evidence of glenohumeral arthritis is present, can be, not always. The passive range of motion increases as you move from 45 to 90 degrees, and the reported pain is reproduced with palpatory provocation of the subscapularis myofascia. Means that if I palpate the subscapularis here, and then I do internal and external rotation, it is painful. Okay. The upper limb nerve tension testing test reproduces the reported shoulder pain. Shoulder pain is reproduced with palpatory provocation of the relevant peripheral nerve entrapment site. Oh yeah, okay. If there is nerve entrapment, you must exclude the adhesive capsulitis. Okay, thank you. And then for the intervention, non-operatively, we can choose oral medication, NSAID, painkiller. If it's related then to myofascial pain at other sites, we can give muscle relaxants, corticosteroid injections, exercise, joint mobilization, distension of the capsule, acupuncture, manipulation, nerve blocks. Manipulation means that we manipulate the joint so then the range of motion will increase more than we do exercise. Okay, but should be done by person with expertise. Okay, you don't want to give more pain to the patients. This is the treatment. You can follow this treatment, but for the interventional pain management, as has shown to you previously, there's no picture of how to do the glenohumeral joint injection. This is how we do it. Put the patient's arm in internal rotated way, touch the contralateral shoulder, and then put the linear probe or curvilinear probe just below the spinal scapula. Here, this is shoulder, this is right shoulder. Okay, this is clavicle, right clavicle, and then this is acromion. Between there's a gap called acromioclavicular joint. If I move it there laterally, you can see this is the head of the humerus, and I rotate it this way, so you can see this is scapulae, right scapulae. Here is the spinal scapulae. Okay, I put the probe just under the lateral edge of the spinal scapulae here, okay, like this. Put the probe here transversely, so then we will see this structure. This is humeral head. Why? Because we are above, just above the humeral head. Okay, and then at the medial side we will see the glenoid here, and the triangular shaped one is this, the labrum. Okay, this is the infraspinatus tendon, and above it is the deltoid muscle. Okay, the capsule is here, this one. Okay, So the direction of the insertion of the needle is from the lateral here, lateral side to medial into the capsule here. We do the hydrodistension of the capsule together with the steroid injection. The steroid injection is 30 mg of triamcinolone plus lidocaine 1%, 10 cc, because the capsule capacity to accept fluid is in between, ranging from not more than 20 milliliter. Okay, do not break the capsule by doing the hydrodistension. Okay, this is about the supraspinatus tendon. I will not talk about it because it's not related, except if then, because of the frozen shoulder, then the supraspinatus become inflamed. It can be, okay? But in my case, previously there is no supraspinatus tendonitis or tendinosis. Okay, this is acromioclavicular joint involvement, which I explained previously, that all the girdle here can be disturbed because of the frozen shoulder that happens at the glenohumeral joint. The AC joint can be inflamed also. Okay, then I will not talk about it, but in my case, I do intervention using ultrasound. We can do the treatment using C-arm fluoroscopically, but then it is done by performing the intervention by putting the patient in either prone or supine position like this. The aim is into the glenohumeral joint, actually into here. Okay, but using fluoroscope to reach the glenohumeral joint, the insertion of the needle is done by piercing the acromioclavicular joint here, this way. Okay, this way. Insert the needle through the acromioclavicular joint, and then it will goes into the glenohumeral joint. So this is the picture where the needles from the acromioclavicular joint will go into the glenohumeral joint. Give the hydrodistension into the glenohumeral joint and withdraw the needle right before reaching the acromioclavicular joint. Stop there and do the actually it is the subacromial subdeltoid bursa injection, but it cannot be too precise compared to the ultrasound procedure, because in using ultrasound we can see the soft tissue, while using the fluoroscope we cannot see the soft tissue, we can see only the bones here. So that's why I will not suggest this procedure for frozen shoulder, except if you don't have ultrasound. If you have ultrasound, use the ultrasound. Is the best way to do intervention for the frozen shoulder. Okay, so the needle will goes into the clavicle. This is acromion here to the joints, like this, into the glenohumeral joint. So if I draw, I use this one. Okay. So I insert the needle into the AC joint, goes through the glenohumeral joint. This way, okay. Put contrast inside. Once the contrast is inside the glenohumeral joint, we will see this solution, the green one, means that it is already correctly placed, the needle. and then we do the hydrodistension just like we do the hydrodistension using ultrasound. 30 mg triamcinolone with lidocaine 1%, 10 cc until 15 cc the maximum, and then pull out the needle until it reaches this side, means that it is above the supraspinatus muscle. But then if there's no bursitis of the subacromial subdeltoid bursa, there is no supraspinatus tendinitis, it is useless actually. But for the intracapsular injection, it is okay. So if the diagnosis not include the subacromial subdeltoid bursitis and not include the supraspinatus tendinitis, just do one step only. Do not add medication into the SESD bursa, and do not also give injection into the SE joint. Okay. Then I proceed to the next slide. Okay, about the suprascapular nerve block, it is the branch of the this is brachial plexus. Okay, C5, C5, C6, C7, C8, T1. Okay, to memorize it. The C5 and the C6 will become upper trunk, the C7 will be the middle trunks, the C8 and the T1 will be the lower trunk, right? The suprascapular nerve is the branch of the upper trunk here. Okay, and it will innervate the supraspinatus and infraspinatus muscle and the posterior and upper part of the glenohumeral joint. That's why we can do the suprascapular nerve block to treat the frozen shoulder to reduce the pain. In the what stage that you write down before? Before the frozen is the first and the second and the third stage where the pain is still there. Okay. Then I will proceed to the next slide. Okay. Previously is the schematic of the brachial plexus diagram. This is diagram also, but similarly to the actual one. This is C5 roots, C6 roots combined become trunks, where then the suprascapular nerve will branch there. Okay, then to the next slide. Here at the upper trunk is the suprascapular nerve branches from the upper trunk. Okay. It will innervate the this region. The cutaneous innervation is here, but for the muscle, it will innervate the supraspinatus and infraspinatus. It comes into the suprascapular groove here, down under the suprascapular transverse ligament, superior transverse ligament. This is the scapula, this is the spina scapula, this is the groove here, suprascapular groove. Can you see it? This is scapulae, this is spina scapulae, this is suprascapular groove. Okay, so how to proceed? We put the probe here at the cranial of the supraspinal scapula, means at the supraspinatus fossa, here at the 1/3 lateral. Okay. Then this is how we do it. This is a reminder. This is trapezius muscle, supraspinatus muscle, transverse ligament, where down under is the artery, vein, and nerve of suprascapular. Okay. The evidence base of interventional pain medicine for the frozen shoulder, it is said that corticosteroid injections level of evidence is 2B plus means it is here, positive recommendation, so just do it. And we have a lot of frozen shoulder cases, right? And for continuous cervical epidural infusion, the recommendation is 2C plus. 2C plus means considered. But the source of pain, if the inflammation is there, just treat the source of the pain. Do not use the cervical epidural infusion if we can do the corticosteroid injection into the venohemorrhagia if the inflammation is still there. Pulse RF treatment to the first subscapularis 2C plus. If then we need long-term or almost permanent pain relief when the patient cannot do the do and don'ts, then the pulse RF is considerable. Okay, this is the exercise. Become a rehab doctor first to be able to do so. Or if you you have no rehab doctor, you can follow these exercises for your patients. Okay. Phase 2 treatment, I will not talk about this. Okay, so this is rehab stuff. I will skip it. So about the home maintenance program, this is the most important part because we just give the patient only 1 or 2 treatment, but then daily the patient has to do so much stuff. Continuous stretching program every day, not only 3 times weekly, but every day, 3 or 5 times a day. Prefer daily range of motion stretching, self-capsular stretches, rotator cuff and scapular stabilization program to begin once functional range of motion restored. And activity modification means that if the patient cannot reach a higher degree, do not force himself or herself to do so, because then it will break the capsule and it will cause damage and then causes pain again. So then
we have a FIPP course in the next August until November.
Yeah, the frozen shoulder is just one of millions of cases that can be treated using interventional pain management procedure using ultrasound. So because 80% of the pain that suffered in patients comes from MSK, musculoskeletal problems. The next is nerve, and the last is spine actually. So we must master the MSK and the nerve, so then we can help our patients more.
You can still take the pain.
Yeah, for sure.
Thank you for the explanation. Let me see. Any questions?
Is there any question? No question?
We have Davina Ophelia, Rival, and Dr. William.
Okay, any question, please? I am tired of speaking now. Your turn to speak. Speak up.
Ask about your patient also.
Okay, sure.
Last one we have Dr. and Dr. Wahida.
Halo Prof, Dr. Teni, Dr. Wahyuni, Dr. Nanita, Dr. Wahida. Please ask 1 or 2 questions. If there is question. If there is no question, means that you all can already do the frozen shoulder cases. Okay? But don't miss the diagnosis as frozen shoulder if it is not frozen shoulder. If it is OA, treat it as osteoarthritis. If it is tendinitis, treat it as tendinitis. If it is only nerve entrapment, do nerve entrapment procedure. Okay. Okay. No question? Okay. Hope you can already do the diagnosis. You can already do the history taking, the physical examination for frozen shoulder. Then you come to an end that it is frozen shoulder and can treat your patient well. Due to the stages of the frozen shoulder, because not every frozen shoulder should be treated just like me doing it. But whether you give medication, whether you give intervention, not operation, of course, the rehab should be done all the way. Okay, because the mobilization is the cure actually for the frozen shoulder. The manipulation.
Face that for doing the
range of motion. Previously, years ago, the orthopedics usually take the patient to the OR and give sedation to the patients and move the shoulder. Once then the patients referred to the recovery room, the pain becomes worsened. So then, as long as I know that the mobilization done under anesthesia is already abandoned, but manipulation done by rehab doctor, I don't know. But in my point of view, once the tissue is broken, means the tissue is damaged, the pain will be there. So means the benefit of the achievement of the improvement of range of motion compared to the pain caused by the manipulation, if then the benefit is more than the pain, means that the state of the adhesive capsulitis not increased more than previously, then it is worth it to be done. I don't have experience about manipulation. Do you have any? I don't think so, because then the orthopedist already abandoned it also.
Dr. Temi, in patient with frozen shoulder, what is the precaution before the
precaution? The precaution for every interventional procedure is always the red flag. The red flag means there should be no cancer, should be no infection, should be no trauma, no fracture. It is general precaution, but for certain cases, of course, we must know if the patient got medication for pengencer darah. What is pengencer darah? Yeah. Yes, something like aspirin, thromboaspirate that will prolong the bleeding time, that we must pending the procedure for 5 until 7 days. So then the effect of the medication has already gone, so that when we do the intervention, the probability of the prolonged bleeding time, if there is bleeding, will be less. And then if the patient has fear to have intervention, do not force the patient to have the intervention, because then if the patient faints at our place, or for patients with an ability to give consent, do not do intervention. Although maybe, for example, his family wants to do so, must do it under strict informed consent. Oh, 11 years old boy, quite good, quite good, quite good.
He can
He can move more now. The range of motion has already increased.
the consent of
The consent from
the parents.
his parents, from his parents.
He also did not refuse for the injection.
He didn't refuse because he's an athlete. He wants to comes back to the sport. Yeah. Oh yeah, the blood, the sugar blood level should be not more than 300. For me myself, in my daily experience, I do not want to do intervention if the blood sugar is more than 300. But the literature is different from the journals. Okay. Because one of the side effects of corticosteroid injection is the increasing of the blood sugar level. Okay. Okay. Hope you get benefit from this case and updates. Hope you can apply it to your patients. But please be careful about the diagnosis, because if the diagnosis is wrong, then there will be no improvement. Most welcome.
Thank you, doctor, for watching, and don't forget, if you the other side, we have the audit also. Next, we'll on the YouTube of PN. Thank you and goodbye.
Bye.